Yes, sir.
Thank you, friends. Good afternoon. Respected Chairperson, my thanks to Dr. Krunal. Where is Dr. Krunal? He's been inviting me to come for this Daman session in Vapi or Daman for last 2 years. Finally, the time has come. Thank you, Krunal, for calling me and for asking me to moderate this wonderful panel discussion. I hope you agree it will be wonderful with such esteemed panelists. I'm having a couple of ex-presidents of IIP on my panel, so I'm feeling overwhelmed. Okay. The discussion is on child with recurrent infections. And before I go, let me introduce the topic to you. What exactly are we going to talk about today? The first thing we need to think of when we have a child who's brought to you when the mother says, "Isko ghadi ghadi bukhar aata hai." I mean, it's such a common thing that you'll see. The first thing is to confirm that it's a recurrent infection. Because there are options. One option is sometimes a single infection comes with recurrent fever.
Sir, just a minute, Dr. Prabhu. So I think our session is 45 minutes. They have put only 29. So
Yes, it's 35 minutes. 40 minutes, yes. President has said, so it has to be done. Okay, so we need to consider other possibilities before we label this as a recurrent infection. You can have a patient who has a single infection, who takes incomplete treatment, he gets fever again and again, that is not recurrent. Like you have a patient with TB who defaults, or very much more commonly, a patient like with UTI in your outpatient, or with infection like otitis media or sinusitis, which really requires 10 to 14 days of treatment, where you give a shorter course thinking that it's a simple infection that does not need a 14-day treatment. So this is an unrecognized UTI, sinusitis, or acute otitis media. So the fever comes back in a few days. That's the same infection which has come back, so it's not a recurrent infection. We also know that sometimes patient can get, even after a complete course, get a relapse. That can happen in typhoid fever and can even happen in Vivax malaria if you haven't given Primaquine. And we know that some fevers, some infections come with recurrent fevers. Some infections come with recurrent fevers. And these are some examples. You're all familiar. I won't go into that. In fact, the last one is called relapsing fever. So you know the fever is going to come again and again. Don't mistake this for recurrent infection. That's not what we are discussing today. Now, if these are ruled out, can we say that we are now dealing with recurrent infections? You think so? Yes? How many of you think yes? You might say yes, provided we have excluded non-infectious causes of recurrent fevers, which we incorrectly label as infectious. We have some examples here. And many of the times I'm mentioning this because many of these times we keep on giving antibiotics to these patients and then we start investigating, we might want to investigate them why this fellow is getting recurrent infection when he doesn't even have an infection at all. It may be an autoimmune disease. We have Pell-Epstein fever, which you see in Hodgkin's. And of course, we have many autoinflammatory diseases like FAPA and so on, where you get recurrent fevers every month or at other intervals. Okay, so once we have got rid of this, then we are really talking about recurrent infections, which are going to concern us and it's going to concern this panel. I'm going to ask them the questions. What are we talking about now? 2 episodes of different confirmed infection, not the same infection, with a definite inter-episode period of more than 3 days. It may be with the same or with a different organism. It may occur at any irregular intervals. And we would be especially more worried if it is affecting growth or causing organ dysfunction. Okay, so this is what is going to concern my esteemed panelists today. So I'm going to start with cases because I'm a great fan of Sir William Osler, the eternal great clinician, who said medical education is at its best when it begins with the patient, continues with the patient, ends with the patient. So let's talk about cases. I want to talk about patient with recurrent URTI. I'm going to show you a case. Azhar, aged 26 months, is brought to your clinic by his parents and he says cough, cold and fever, slight fever for last 5 days. And when you ask for the past history, the mother says he's been getting such episodes every so often for the last 1 year. On inquiry, she says also that there have been episodes of ear pain and there was some discharge from the left ear for a few days 4 months ago. So I'm going to, Dr. Bhadra, can you take this?
Yeah.
So what would be your approach when you have a mother who brings this child to you?
So we must remember that this age group, it's almost natural to have
certain episodes of infections. What I think is sensitizes the mother or the parents is that the children at this age, they are obligate nasal breathers. So slight obstruction might create difficulty for that child. And he might remember the difficulty, and it would seem to the mother that he is continuously having infections. But there are definite interval periods where the child is okay. And the pediatric airway and the adult airway, later on the airway increases and the size increases. But this age group, the airway, the lumen of the airway is very less, and a slight obstruction creates disturbance for the parents, for the child to breathe. So I think the approach should be a history, should be look at the environmental history, should look at what treatment we had given. Often no treatment is needed if it's almost viral. Whether there has been a history of surrounding, of family history of any eczema or atopic episodes for the parents and for this child also. Because we know that it starts with often the allergic march. It can start with the skin. So skin should be one point of focus for the pediatrician to look into it. And of course, what is the pattern of the associated fever, whether they had very high fever, whether any investigation was done at that time. I think all this should be put into and associated with the history would lead us to a point.
Thank you, Dr. Atanu. I think he's rightly brought out the point that many of these infections are not infections at all. They might be allergic episodes which keep on recurring. The slight fever is what sometimes the mother imagines because the forehead seems hot and they think it's a fever, and you might be misled into thinking that there is an infection when there actually is an allergic episode. Thank you, Dr. Atanu. But what would you look for in the examination, which might tell you that this is truly an infection and not just an allergic episode?
Yeah, we'd look for the nasal, is there any signs of nasal obstruction, allergic shyness, or the lines, the pharynx, because sore throat is the commonest presentation of the children in this age group, but it's always that this child hasn't crossed 2, so probably you won't be having any idea of the sore throat. The mother might complain that the child was not feeding. So whether there was the throat is inflamed, whether there is any membrane over it, that could lead us to a point whether we need to, or lead us to a decision whether we need to give antibiotics to this child.
Okay. So I've shown a couple of pictures here of what definitely is infection. Like that's the pharyngitis there with tonsillitis and of course an acute otitis media. Would you do any tests or investigation, sir?
Often no investigation is needed.
Okay.
But if the parents are anxious and as a pediatrician I need to have some more inputs, I can go for an X-ray for adenoids and some tests for allergy to prove to the parents.
Fine, thank you. So it's all essentially clinical, and very often we can find out which patient really has a problem or not. And as Dr. Atanu rightly said, most common cause of recurrent URTIs are self-limiting, non-specific minor viral infections. And we remember that they average 3 or 4 times a year. But you get an average when you get some people who have less and some people who have more. So up to 8 per year is still common to make it 3 to 4 average for a child of that age, which means that the mother will say, "Har mahine mein hota hai." So don't lend this, and this is from the Royal Children's Hospital in Melbourne, which say that in their experience it can be up to 12 times a year, so that the mother keeps saying that the child is having respiratory infection all the time. So this is most of the problem that you will see in children who are brought to you for recurrent URTI.
Sir, can we
but
make
the question really is, yes, Dr. Bhaskar, you want to add?
Sir, one of the other things is most often bottle feeding. The child who, if it is a younger child.
I was going to ask you the right question.
Yeah.
See, because some mothers say, Dr. Saab, you are saying average is 3 to 4. Why is my child getting 8 times or 12 times? So you're trying to answer that question, right?
That is one
That's
thing.
exactly what I was going to ask. Why do
And
some
second
children
thing
have
is
more
a child who goes to early schooling, the creche, the daycare or whatever you call, the chances of getting infection from 1 to 1. And there are various other factors which you have shown.
Okay, I think some of them are listed here. Upendra wants to add
So
something?
the scenario that you have given is one of the commonest one that all of us see in day-to-day practice.
Yeah.
And we have to just as clinicians in busy practice differentiate into only 3 categories. Whether the first one, as you said, is it a typical viral infection that frequent episodes, is it fitting into that? Or is it a hyperreactive airway disease wherein I need to not think about giving an antibiotic or something like that.
Right.
And third, whether it is a true bacterial infection.
Right.
So I think only fever, cough and cold, 3 basic symptoms can help us. In a bacterial infection, your fever would be really the predominant symptom. Whereas in a viral, as you said, slightly, thoda sa bukhar, badan garam lagta hai. So all those they wouldn't be documenting. Whereas in a hyperreactive, my cough and cold would be a more predominant symptom, wherein the child would be doing that typical itching of the nose, sneezing and all such kind of things which are predominantly pointing towards probably a hyperreactive.
I think that's a very good approach, very simplified approach that we should all. But I think Dr. Bhaskar listed some of these. The reason why I think we should look at these is because these can be addressed. If you can prevent passive smoking, you can reduce the number of infections in that child. Don't send a 9-month-old child to a playgroup in a closed air-conditioned room with 9 or 20 other children, half of whom have running noses. That's a situation where your child is going to get recurrent infections. Poor hygiene, bottle feeding, Dr. Bhaskar already said. The important thing, I think, is to remember that most of these patients will only have infections confined to the upper respiratory tract. That's a kind of a good point for us, that this child has never had a pneumonia, never really had diarrhea, never really had a deep-seated infection, so I know that we don't have to worry. And as I said right in the beginning, if this child is not really having effect of his growth or any organ dysfunction, then it's okay to just treat him. Dr. Bakul, you want to add something? Okay.
I think cough is another pointer. In the viral infection, the cough would be more distressing to the child. If we are thinking of a bacterial infection, cough probably would be the second.
But even in a hyperreactive area, you get a lot of cough.
Yeah, lot of.
The other thing, as I said, if you treat the hyperreactive area, you treat that again your infections will come down. So it's important to identify these factors. Okay, let's go to the next recurrent infection now, that's a recurrent pneumonia. Now this is defined, this is just a definition, 2 episodes of pneumonia in 1 year or 3 episodes at any time frame. We need to differentiate from a persistent pneumonia by the presence of a symptom-free interval, preferably also documented by an X-ray showing clearing. Now that does not always happen, because the standard recommendation is you don't necessarily have to repeat an X-ray in a patient with pneumonia who goes home. It's not my practice to do it also, I don't know what you do, because sometimes the X-ray takes 2-3 weeks to clear. And at 3 weeks, when the child is fine, you can't call the mom back and say, let's get an X-ray done to find out whether the X-ray has cleared. So that doesn't happen. But we need to confirm that there are recurrent episodes of pneumonia and not just Walgry, which would be very common in a hyperreactive airway child. Okay, let's come to the case now. 20-month-old boy fully immunized. I thank Dr. Bhaskar for giving me this case, and I'm going to address the questions to you since you had dealt with this child. 5 episodes of pneumonia starting at 13 months of age. In all episodes, he had the usual symptoms, fever, cough, respiratory distress, but initially didn't have hypoxemia. He had respiratory signs on the examination. He recovered well every time on the outpatient with antibiotics and symptomatic treatment. Seemed to be pretty well in between the episodes. What are the possible causes that crossed your mind, Dr. Bhaskar?
See, it is first of all, as you told, you clearly told that how to differentiate between a persistent and a recurrent pneumonia. And having said that, this child is having, though it is immunized, it is having a much more recurrent, like 5 episodes.
Yes.
And usual causes, we have to look at the anatomical, we may have to look at the congenital anomalies, both in the upper respiratory tract and in the lower respiratory tract. Then whether there is some condition which is causing recurrent aspiration. It could be in a young child, it can be a recurrent GERD, which can be there, or the child may be having some kind of muscular weakness. Even in those who have some CNS disorders, they can get those things. And when you have ruled out those things, some of the little unusual, or I would say, we are not tuned to it. For example, cystic fibrosis is one thing which generally causes, and the PCD. And then there is something which is compressing, maybe even in a tuberculosis, where in endobronchial tuberculosis, the lymph node compresses, and that can sometimes cause. And when you ruled out everything, the final thing is the immunodeficiency. Because I have quite a few patients who are IgA X-linked hypogammaglobulinemia. So those patients, they can also come with recurrent infection. But in such children, one of the most important, commonly missed is a foreign body. Because sometimes if you ask also, the parent may not remember or may come out with a history. So that is one thing in all the children we have to keep in mind. And you have to look at the X-ray, whether there is any...
Okay, yeah, we'll come to the X-rays. But I wanted to ask you two questions before we go ahead. One is, can you, I've listed all the causes on this one slide. Would you say age groups matter? Because your anatomical cause, what age would they likely to be present? Remember, this child is 26 months old.
A child who gets very early infections, the possibilities of congenital infection, congenital anomalies, which is missed, comes first.
Yeah, they would present earlier. And my second question before I go ahead is, if you exclude the anatomical problem which are going to present early, would you say this is relatively the order of thought that should cross your mind, or should you think of immunodeficiency first?
No, immunodeficiency causing recurrent infection, of course it can, but I would put the recurrent aspirations like foreign bodies and...
Fine, thank you. I think you made that point very clear. Our delegates understand that we should not jump to the cause of immunodeficiency when you have recurrent pneumonia, at least not initially. Because when you have immunodeficiency, we're going to see a case later. There's going to be much more other types of infections too. Yes, come to your approach, Dr. Bhaskar. What did you do in this patient? I think you did a CBC and a chest X-ray. Can you show the chest X-ray?
Pardon?
Or you want to talk about the...
yeah, the routine investigation anyhow we are doing, but I would review the previous X-rays. That is one thing. And whether there is if I'm lucky to have a inter-period normal X-ray, then probably I'm... So if we are lucky enough to have a X-ray, sometimes it may not be.
So shall I show the audience the previous two X-rays?
Yes, please.
Okay. This was done, this is the current X-ray. That was the previous episode, which was a couple of months ago. So what would you make?
So we really don't know what, because it is they came to me late, after all the medical shopping. So I really don't know what is the in-between inter-period X-ray. It should be normal. And literature also says it is very difficult to differentiate between a persistent pneumonia and a recurrent pneumonia.
Correct.
And in this case, the opacities are almost persisting. So in such cases, we may have to go for further investigation.
Would you say, Dr. Bhaskar, that the fact that the pneumonia is in the same spot in both the X-rays is significant?
Both the X-rays...
Suppose pneumonia was on the right lung 3 months ago and today it's on the left. Would you draw some different conclusion?
See, if it is in this, whether it is due to anatomical or functional, if it is a structural defect, always it will be in the same site. Right. And if it is due to some functional or immunological, it can be different sites. Okay. So that gives a clue to whether it is a anatomical or a functional.
Yes, very important clue. If it's at the same site, think of some local or anatomical or structural problem. If you have the pneumonia once in the right lung, second time in the left lower lobe, you think of some other causes, not anatomical or local causes. Okay, these are some of the other tests you did. Can you tell us why they were done? I'm just taking this list from what you gave me.
Yeah, chest X-ray, of course. 2D echo, of course, it was done before they came to me, but clinically, child didn't have any
cardiovascular cause.
To rule out anything. And the HIV ELISA also was done. Yes, I did only the CT chest, just to make sure that whether there is any defect in the anatomical region. And then, of course, the one important thing is we have to do a
We should think of TB in our country.
Yeah.
It's so common, and it's So that was also done. What about the chest CT? The last thing is chest CT. I'm going to show the chest CT, but can you tell us why you thought of doing a chest CT?
No, it is mainly the defect. The X-rays were definitely showing some abnormalities. Whether there is any hidden obstruction or a congenital anomaly something like a C-cam and other things, sometimes they can present like that.
Okay.
Maybe a little later, but
Yeah.
to rule out those things, we did.
Yeah, since the pneumonia was at the same site, you thought of a structural lesion, therefore the CT is very important in these cases. If it was on different lobes, that would not have been so important, correct? Is that the message? Thank you. So this is what this CECT showed. It says subsegmental consolidation with some atelectasis, right upper lobe, diffuse hyperlucency of the remaining parenchyma, and overexpansion which has caused a bit of a shift. You can see that at the top, that lobe looks, does this work? I suppose this will work. No, that is just the movement. Okay.
It won't work on LED.
Anyway, it doesn't matter. I think you can see what I mean, the hyperlucent zone.
Yeah.
Okay, where the star
The
is there.
asterisk can.
Yeah, where the asterisk is there. Oh, this is not the one. This is the one. Oh, thank you. I'm using the wrong one. Yeah, this area is of course hyperlucent. And the right upper lobe bronchus shows an abrupt truncation there. You can't see that very well on the projection, but I can see it on my screen. And therefore, Dr. Bhaskar thought of a foreign body aspiration. So what would you do next, Dr. Bhaskar?
See, in fact, we suspected foreign body. We kept on asking. They never told these things, because usually the episode starts with while eating and they suddenly start coughing. We asked them, but they never gave that history. But bronchoscopy was done. We have a pediatric pulmonologist who did the bronchoscopy, and this suspicion of foreign body was, in fact, came from the radiologist. Though we suspected, he told me that there is a possibility of foreign body or some obstruction. Then we went ahead with the bronchoscopy, and that confirmed some.
So I think very important message that you don't always get a history of foreign body aspiration. That should not stop you from doing a bronchoscopy. Is that right, Dr. Bhaskar? Yeah, okay. Thank you.
Sir, can I just add one?
Yes, Upendra.
So
I
point
mean,
out-
anybody else, please. I'm just talking to Bhaskar.
Yeah,
because
yeah,
in
it's
his
okay,
case,
perfectly
anybody
all
of the
I think all of us see foreign bodies once in a while. But the tracheal foreign body is very easy to identify, and it comes as a shocking event, and we usually diagnose it. But when we go to a bronchial foreign body, it usually takes some time. So we may not get this eliciting this history is very important. And second point is X-ray can also fool you. So atelectasis, minimal area of consolidation, may not be very evident, and many of times this radiolucent, so they may not be visible on the X-ray also. So that again you put, okay, it's not seen there, so probably it is not foreign body. So high index of suspicion continues to be there. And before going for this immunodeficiency workup, I think this was logical that going for a CT and then pursuing it and eliciting the history and probably removing the foreign body was important.
So very nice. Dr. Upendra said high index of suspicion. That's the message that you need to think of a foreign body. Okay, we come to the now third example of recurrent infections. We're going to talk about recurrent urinary tract infections, defined as at least 3 episodes of UTI in 12 months or 2 episodes in 6 months, preferably documented with a urine culture, because you know so often you get pus cells in the urine for various other causes. We'd be happy if you have 2 documented urine cultures, 2 episodes in 6 months or 3 episodes in a year. Okay, case again. And I'm going to, who's going to take this case? Dr. Bakul. I'm going to give it to Dr. Bakul. I think you only send me some details about this. 8-month-old Nikita brought with several episodes of fever, vomiting, dysuria starting from her 3rd month of life. And there was, mother brought several reports showing pyuria, proteinuria and positive nitrite tests. Not cultures were not done, but I think this reasonable conclusion that this patient did have recurrent UTI, because each time she was prescribed an antibiotic, she would respond and then get another episode a few weeks later. So, Dr. Bakul, what thoughts cross your mind?
Yeah, so first of all, this is a confirmed case of recurrent urinary tract infection as shown by urine analysis, and nitrates are quite specific.
Yes.
To a level of 98%. And it has started from the age of 3 months and is going on till the age of 8 months or 9 months. So definitely there has to be some obstructive phenomena or anatomical defect which is causing this recurrent infection, or sometimes it can be vesicorectal reflux, or sometimes bowel bladder dysfunction. So that can be combined also, like VUR as well as bladder bowel dysfunction, especially being a female child, this is very likely. Also, sometimes hygienically they may not be keeping the child well, and that also can cause recurrent infection. But then this is very likely to be upper urinary tract infection because protein is also there and it's coming again and again, and child looks to be quite toxic. Of course, I would like to look at the growth of the child by plotting the growth chart, and if child is doing well, it's okay. Otherwise, definitely this requires urgent attention to rule out this.
So very important message, if the child is an infant, definitely think of an anatomical cause. The younger the child is, the more the likelihood. Like Dr. Bhaskar said for recurrent pneumonias, the younger the child is, the more the likelihood of having some kind of an anatomical defect. These are the common ones, they are listed here, we won't go through.
Sir, one thing I
What
want
about
to
older
stress is
children? Yes, Bhaskar.
one thing, the vulval synec, most of the times we don't do the local
Yes.
examination. That is one thing, with the simple manipulation, I think we can get rid of this. It is imperative that we do a clinical examination, a child who comes and look for these things also.
I think so. I think very often if pediatricians don't even look at tight phimosis, which is another cause in a male child. But vulval synec are often missed. I've had several patients. Simple local examination tells you the problem and that can be treated. What about an older child? We said younger child, we think of anatomy. What about, suppose the child is 2.5, 3 years of age. What do you think of?
So as you rightly said, there can be tight phimosis, there can be PU wall, there can be sort of constipation, or maybe there is dribbling of urine or frequency of urine, or maybe double voiding. All those things suggestive of bladder bowel dysfunction. And uncircumcised male child is very likely to get recurrent urinary infection because of that. So keeping mainly in mind bladder bowel dysfunction as well as PU valve and tight phimosis.
So if you have an older child who's been well for the first year or year and a half and now starts getting UTI in his second or third year, you start thinking this is a time when you do toilet training. So we think of bladder bowel dysfunction. But I think Dr. Bakul gave me this very nice slide which I was not aware of. I'm going to show that. Is the fact that many of the times there is an overlap. Look at the slide on the right. In older children, 20% will have VUR, 35% have bowel blockage dysfunction, but a significant number will have both. So just because the child has some constipation or problems with toilet training, and how do you recognize bladder dysfunction? It's listed there: urgency, holding maneuvers, hesitancy, frequency, weight. So you have to ask for this history, and then you think, of course, of a bowel bladder dysfunction, look for constipation, but don't forget that there may be an overlapping anatomical.
And sir, here wetting of pants mainly during the daytime, during the waking period.
Yes.
And also encopresis. These are two very important indications.
Correct. Encopresis is another very important sign. Okay. And of course, then we have obvious neurogenic bladders. They're going to get recurrent UTI. It's not worth discussing. If the child has a extropia bladder, or he's got a spinal dysfunction, or he's got a meningomyelocele, we know these patients are going to get.
Sometimes occult meningomyelocele is missed.
That's obvious. So let's not discuss about that. That's an obvious disease. So what tests would you do?
So as it is now a confirmed case of urinary tract infection, but there is a present infection, definitely I like to do urine culture.
Yeah.
I may not depend on pyuria, but because there is a recurrent infection, we have to go for urine culture.
Yeah.
Properly collecting urine, as all of us know, as per the age. And then, of course, go for the detailed examination, like maybe initially your sonography, and then micturating cystourethrogram. Or nowadays, there is a sort of enhanced urosonography, where you can avoid.
We'll come to that. But I think important in the examination, examine the genitalia. Dr. Bhaskar pointed out that we don't really look for vulval synec. Look at the lower back. Sometimes you get a occult spina bifida, which can also cause problems in voiding or constipation. So look for a sinus, tuft of hair, nevus, or whatever, and examine the anal sphincter and tone in the lower limbs, which sometimes is not very obvious in a young child. Very important message. I don't know how often we can do it. Try to watch the voiding if possible. I sent to our pediatric surgeon and say, have you watched the child pass urine? Because that gives you a lot of information. Sometimes, fortunately, the mother will bring you a video, or else you can ask the mom to show you a video, and that can give you a lot of clue. You can find out whether there is problem in initiating the micturition, whether there is a disruption of the urinary stream, how strong is the stream, and so on, and that can give you a clue. Yes, now go ahead with the investigations. You were talking about the investigation.
So any child below the age of 2 years, you have to do, any child of UTI, we have to do USG first to look at the kidney size or any other structural anomaly. And then, of course, we should go for MCU after, say, about 2 to 3 weeks of treatment, and look for VUR especially, and maybe some of the obstructions like PU in a case of male child. And later on, if there is a problem with the kidney size, or if there is an atypical infection where it is other than E. coli organism, or fever started with more than 102, we'll go for DMSS scan after about 4 months.
Okay. I think the audience is very familiar with this approach. There is a IAP guideline also on this from our urological group. Upendra, you want to add something?
Yeah, just
So it's very clear. Let me just finish. A USG in every child with infant. Definitely if it's an atypical UTI where you think something is likely to be wrong, the older child assess for bowel bladder dysfunction, and once it's recurrent, you start doing the whole thing, including the MCU and a DMSA, which we rarely do. Yes?
Yeah, just 2-3 points regarding UTI.
Yeah.
I think as an exception to the earlier case of URTI and other case where we have no conclusive evidence of that infection, in UTI we have to confirm it by doing blood culture, number one. So then only we can call it recurrent. And secondly, if there is a doubt, because all of us are talking about antimicrobial prophylaxis and prevention of VUR. Entire world is deliberating whether how long you should give, whether you should give, how much does it make difference. But one investigation which is a must for every UTI is sonography.
Okay.
So I think that is second point very important.
Thank
to
you. I
understand.
know there's a lot of
And
things
third,
to do.
sir, just last very
But there are
important
only
point.
11 minutes left, so I'm not talking about the treatment. I didn't talk about the
No,
treatment.
that is
in any-
third very important point. Forget everything else. But if you want to make bladder happy, make bowel happy also.
Very
So
good.
constipation.
Nice message. Make the bowel happy, the bladder will be happy. Okay, let's come to case 4, recurrent diarrhea. 5-month-old Shanai brought with fever and loose motions for last 3 days. Mother says the child vomited twice 3 days ago when the fever started. And since then the child is passing 5-6 stools every day, which is slimy and sticky, and she says it has a foul smell. And when you ask, the mother says, oh, yes, every month this is happening. For last 3 months it's been happening. And each time she gets medicines, either from the local chemist, which unfortunately happens, or from a local family doctor, and the child improves. So she forgot about it till the next episode. So what thoughts cross your mind? Who's going to take this? Upendra, come on.
Yeah. So I think this is a typical age group that
I'm
you have.
sorry, I'm calling him Upendra. Dr. Upendra.
Sir, please. So it's a 5-month-old child who has come to you with a complaints of recurrent so-called diarrhea. So this is a typical age group whether first and foremost question would be the feeding, the nutrition of this child before going into any infectious causes. Is the child exclusively breastfed or is the mother intermittently or totally converted into top milk? If she is feeding top milk, how is she feeding? What is the method of hygiene, dilution? All those things will matter. She is giving credit to the treatment and the child is becoming all right. It is nothing. The child is getting all right on its own.
Correct.
So that is second very important thing. So once I am aware of it, and a child who comes to me with a recurrent of any problem, the first and foremost thing is a growth chart that I would be seeing. If this child has really a big problem, the child is going to deviate, go down. So point again, we have to emphasize on maintenance of growth chart.
We
for all
agreed
these.
on that right in the beginning. that
Absolutely.
Organ dysfunction or growth should be an important factor to consider in all these cases. And just to list, and I think our panelists would agree that most of the time the recurrent diarrhea are not infections. We need to look at non-infectious causes, which I'm not going to discuss today because the topic is recurrent infections. We all know we have celiac disease, lactose intolerance. In older children, we have inflammatory bowel disease, irritable bowel syndrome, cow milk protein allergy, iatrogenic diarrhea. And okay, so I'm going to skip that. What would you like to ask for in the history, doctor?
So it all starts with the age when the child has come.
Okay.
The second age group which comes, this was the first one, is a toddler age group when we get so-called what is called as functional diarrhea. Again, their faulty complementary feeding is another way. You know the number of children who are given heavy carbohydrate drinks,
Right.
the fruit juices. The child is also having all those simple carbohydrates, extremely high amount. It is bound to cause a diarrhea.
Correct. So
and the child is
non-infectious
going to come.
again.
So again, non-infectious. So they predominate. They come up on the list always for such kind of episodes. If the child is really thriving well. So my always focus would be how is the child doing, thriving well or actually a sick child.
Okay.
If the child appears to be sick, then my antenna would be up for something else.
And
So
you already mentioned about the feeding history and the hygiene history, right? Okay.
Sir, one thing is the cow's
Bhaskar.
milk, CMPA you mentioned, but some children, we don't have a specific test to prove or disprove that. But most of them, when we stop cow's milk, they have improved. Milk and milk
Yeah,
products.
we mentioned cow milk protein allergy. That's a non-infectious cause.
So coming
Okay,
back to
growth
sir, the
chart you
infections
already
part,
mentioned. Yeah.
if you tell me that this child also has diarrhea, he also has pneumonia, he also has some skin abscess, then it's a different
Yeah,
story.
that's a different
So-
story altogether. And lot of tests, but most of them really are for non-infectious causes. So let's not go into this list. Right? Most of them are for infection. Only recurrent infection diarrhea that I can think of is intestinal tuberculosis, which you see can present with episodes of diarrhea alternating with constipation. So it looks like a recurrent infection. They also have fever. So yes, that's the only one really. Otherwise, it's almost always, as Dr. Upendra rightly said, poor hygiene, top feeding. And sometimes I don't know whether you have noticed this, I have mothers who say we are exclusively breastfeeding, but my child still gets diarrhea. And what happens is that there is a maid who comes to give massage, who tries to clean the tongue of the baby by putting the finger in the mouth. I do believe that's an important cause of infection. Thank you. So let's come to case 5 now, recurrent meningitis. 2 or more episodes of meningitis defined by abnormal CSF, minimum 3 weeks apart after completion of treatment. 11-year-old, Bhaskar, this is again your case, so I'll ask you the questions. He comes with standard meningeal signs. I'm not going to go into that. We're running out of time. And he says 8 months back there was a similar history, and CSF had done at that time was suggestive of meningitis, which was treated with 14 days of IV antibiotics, which I think you will agree is an adequate course, and he recovered, and now 8 months back he's come back. What are the possible causes?
There are such patient wherein first we confirm that the treatment has been appropriate and he had recovered appropriately after the first episode, and he gets. So there are 3 most important things. One is the anatomical defects. Probably he had a head injury which is not detected that time, or there is some congenital abnormalities, both in the skull and in the spine.
Right.
It is imperative that we look at the spine thoroughly in such cases, which we are not doing. There may be a sinus, there may be a congenital anomaly, there may be a defect, or there are certain times the immunodeficiency also can. So congenital anomalies, trauma, hidden, undiagnosed trauma or immunodeficiency. These are the 3 important.
What about the parameningeal infections? Are they very common? We talk about this.
Paranasal, parameningeal infection, of course, if you look at the literature, they can be a source of infection when you have not
look at that. The sign.
With the advent of antibiotics, see, some time back, whenever otitis media is there, we used to think of the meningitis.
Right.
Or there is, in the danger area, there is some infection you have manipulated, and then the infection spreads. So these are few things, parameningeal infection.
So I think based on what Dr. Bhaskar has said, our approach should be to look at 3 points of view. The lab tests, you're going to look at the hemogram, you're going to look for peripheral smear for Howell-Jolly bodies. Now this one thing very specific, which I think you know is for asplenia. And the reason why Dr. Bhaskar has put it here is because you get meningitis community acquired typically from capsulated
Sorry to
organisms.
interrupt,
So
but we are left with 4 more minutes.
Asplenia rather than, something like a T cell deficiency or anything like that. Radiological tests again are focused on asplenia. Look for the local anatomical by MRI, sonography, and of course call your neurosurgeon and ENT person to have a look. This patient, I'm going to run through this slide, Bhaskar, because we have one more case to discuss. This patient had a CSF leak from his left nostril after intrathecal administration of a fluorescent dye, and the CT identified that there was a defect in the cribriform plate, and the neurosurgical correction was done, and the patient never had meningitis again. Okay, so these what we have discussed so far are recurrent infections, which I call category 1. What are they? Where you have repeated but similar infections affecting the same organ system. There we should think of an underlying local anatomical problem. Like for URTI, this is what we think of. For UTI, this is what we think of. For recurrent pneumonias, Dr. Bhaskar has already spoken about GR, foreign body, and functional anomalies. Recurrent meningitis, you think of a CSF leak, pyeloneedle sinus. Recurrent cellulitis, at the same site, you think of a retained foreign body. And of course, an environment problem which we discussed in the beginning. But I'm going to come now to a different kind of case. You have a Sanket who's 22-month-old with prolonged fever for a week, high grade. Mother says he has nothing except some vomiting and poor appetite. A sonography has shown a liver abscess. And you say, oh, he needs to be admitted. And the parents say, oh no, this is the 3rd time. He was admitted for a bad pneumonia 4 months ago and 2 months earlier. Than that, for a prolonged diarrhea and weight loss, he is not growing at all. So I think it's quite obvious. I think panelists will agree with me that this is a separate category where you have, Dr. Upendra, you would like to add something?
Yeah, so this is a separate category, as you very rightly said, and good that you put it at the end, because this doesn't come common in our day-to-day practice. So this has to be thought of after everything, and it also has certain clues. That has to be. So when you ask a history of a child who comes to you with recurrent infection, first and foremost, I think very easy to ask about the consanguinity, a male child born, any earlier death in the sibling who has died of any of such things. You may just suddenly get a setback, and you may feel, yeah, this child could also be harboring certain things. If there are recurrent infections, so there are certain guidelines, 10 pointers have been given that how, when, and when you should suspect primary immunodeficiency, 2 or more pneumonias, 4 or more ear infections in a year, the child who requires frequent intravenous antibiotics, the child who has previous sibling death in the family.
Unusual infections,
Oral
difficult
thrush,
to treat infections.
absolutely, oral thrush,
Something takes very
and
long.
child who
Some
is
of them
not
are
thriving
listed
well.
here.
These children will never thrive well. So
Yeah,
this
they
is
never
not well.
thrive well. They have got failure to thrive.
Yeah.
They have severe episodes that respond slowly or poorly to treatment. They occur in any season.
And they may have some deep-seated infections, cellulitis, all such kind of things,
yes.
wherein you should be really
Very true,
thinking about
very true.
immunodeficiency.
So these are the red flags Dr. Upendra has already pointed out. Consanguinity, sibling deaths, early presentation. Usually they come in the first year of life. Male child, we know that a lot of immune deficiencies are X-linked. And high-risk behavior in the parents, of course, should make you think of HIV. So investigational approach, I think we will not go into detail. We have Dr. Nitin Shahar, I always send to him when it needs to be done. So you have, of course, HIV ELISA is one thing you should always do. But then anybody would like to take this? Give us a
Yeah, I think these are basic tests which are available everywhere.
Yeah.
So CBC is always there.
Yeah.
The immunoglobulin profile as well as the T and B set subset classification can also be done everywhere. So delayed hypertension, phagocytic defect is suspected, and of course you have to go for nitroblue tetrazolam test. Bone marrow is also available. The genetic right now you have shown it as last, but maybe in couple of years this may come up, and maybe we'll be having more and more diseases diagnosed genetically.
I think genetic is available everywhere. All you have to do is collect the sample and send it somewhere. So it is available everywhere, although it's expensive.
Especially when we are asking for CBC, please look for absolute lymphocyte count.
Correct.
That may be the first clue.
Very important. Look at the CBC very carefully. If there is absolutely lymphopenia, that's what you should be worried about. So what are the take-home messages? I know I have only 20 seconds left. When faced with a recurrent infection, first make sure that it's truly recurrent, not one infection. Second, make sure you're not dealing with a non-infectious case. Assess the environmental causes first. If it's localized to one part or one system, look for a local anatomical cause or dysfunction. If it's multiple severe, deep-seated or unusual infections, it may indicate an immune system issue. Thank you. Thank you to the organizers for calling me, panelists for such wonderful cases and answers, and of course, audience for listening to me. Thank you very much.